Hi all, welcome back to the emergency medicine lecture series. In today's video, we are going to learn about the basics of mechanical ventilation. Mechanical ventilation is one of the most complicated thing in the emergency department and is usually least taught. If you understand the basics of mechanical ventilation, the terms used in mechanical ventilation, the further things like initial settings, modes of ventilation, changing the modes, when to use which mode will become easier for you. I'm Dr S Prakash Babu, Associate Professor of Emergency Medicine, KIMS and RC, Changalpattu. So first thing you need to concentrate when you are talking about mechanical ventilation is the pressure equivalents. 1 millimeters of mercury is equal to 1.36 centimeters of water. 1 kilopascal is equal to 7.5 millimeters of mercury. 1 torr is equal to 1 millimeters of mercury. 1 atmosphere is 760 millimeters of mercury. 1034 centimeters of water. With this basis, you will proceed on to the mechanical ventilation basics. This is a picture to depict different pressures in the airway. First of all, there is airway opening pressure, mouth or airway opening pressure. Then there is alveolar pressure, intrapleural pressure, pressure at the body surface, airway pressure, that is the pressure in the airways, and there are some pressure gradients like the transpulmonary pressure, which is the pressure difference between the alveolar pressure and the pleural pressure, transthoracic pressure, which is the pressure gradient between the thoracic wall and the alveoli of the body surface. Trans airway pressure is airway pressure at the opening of the airway to the airway pressure at the end of the airway, that is the alveolus. And chance respiratory pressure, which is the airway opening pressure minus the pressure at the body surface. The normal values for those pressures, pressure at the body surface is similar to atmospheric pressure. So effectively there is zero pressure. Intrapleural pressure at the end of expiration is 5 centimeters of water. At the end of inspiration, it's 10 centimeters of water. So you know the pressure in the alveolus at a normal person is breathing is negative pressure. So the end expiratory pressure is minus 5 centimeters of water. At the end of inspiration, the pressure reaches minus 10 centimeters of water, that is lowered. The alveolar pressure in a spontaneously breathing patient during an inspiration is 1 centimeters of water, and during exhalation, it is about plus 1 centimeters of water. So what is the importance of these pressure gradients? The importance of trans airway pressure is that it is required to produce airway flow in the conductive airways. If there is no pressure difference between the airway pressure at the opening of the airways, that is the mouth or the nostrils, to the pressure that is present in the alveolus, there will not be any flow of air. All of you know that air flows against the pressure gradient from an area of high pressure to an area of low pressure. So there should be higher pressure at the opening of the airway, and there should be a lower pressure at the opening end of the airway, that is the alveolus, for the gas to flow into the airway, and vice versa when the expiration is happening. Transthoracic pressure is useful to expand or contract the lungs and the chest wall at the same time. Whereas the transpulmonary pressure or alveolar distending pressure is the pressure that is required to maintain the alveoli in an inflated condition. Some of the concepts in the respiratory physiology you need to understand before proceeding into starting a patient on mechanical ventilation, and understanding the dynamics of mechanical ventilation and knowing how the patient is responding to mechanical ventilation and what modes you should use. The first and foremost is lung compliance. You know the compliance is the relative ease with which a structure can distend. Opposite is the elastance, the tendency of a structure which is distended to return to its original form after being stretched. Compliance is calculated as change of volume per unit change in the pressure. That is delta V by delta P. Normal respiratory compliance is 0.1 liters per centimeters of water or 0.05 to 0.17 liters per centimeters of water. Normal compliance in intubated patients, in males it is 40 to 50 ml per centimeters of water. It can be raised up to 100 ml per centimeter of water. Females 35 to 45 ml per centimeter of water. It can be raised up to 100 ml per centimeters of water. So if you look at this, normal respiratory compliance is about 100 ml per centimeter of water when the patient is spontaneously breathing. But when the patient is mechanically ventilated, the compliance reduces to 40 to 50 ml per centimeters of water in males and 30 to 45 ml per centimeter of water in females. So when you are starting mechanical ventilation, you need to accommodate for these changes in the lung compliance. Next is the airway resistance. You know, the resistance is the opposing force for any action. So if air is flowing through the respiratory tree and the bronchioles, there is a resistance to its flow. The forces which prevent it from flowing in or out. The degree of resistance to the flow of air in the respiratory tract during either inspiration or expiration, it depends on the airway diameter, the flow pattern, and the surfactant. It is calculated by the modified Ohm's law, which states that flow is equal to pressure gradient divided by resistance. It is better calculated using the Paisuli's law, where the radius is 8nl by 5r to the power of 4, where r signifies your radius of the airway. So if the radius of the airway is hard, radius is inversely proportional to the resistance. When the radius decreases, the resistance increases to the power of 4 times. So having the radius of an airway would cause a 16-fold increase in the resistance. Turbulence leads to need for a much greater difference in pressure to move the air. Surface tension and the surfactant. Surface tension refers to tendency of fluid to shrink to the smallest possible volume. You know, a water droplet assumes a spherical shape, which is the shape of with the lowest surface tension. The higher the surface tension, the harder it is for the lungs to stretch. The surfactant is the compound that attaches equally with air and water and reduce the surface tension, allowing the airway to expand. Surfactant acts effectively at lower alveolar volumes. When alveolar volumes increase, the distance between water molecules increases, leading to less effectiveness of the surfactant. So what are the physiologic goals of mechanical ventilation? Until now, we discussed about the physiology of a patient who is intubated and a patient who is spontaneously breathing. Now let us come to the physiologic goals of mechanical ventilation. The primary goals of mechanical ventilation, as a dictum for an emergency physician, either in the pre-hospital or in the ED, you are treating any patient, not only in mechanical ventilation, the dictum is cause no additional injury. There's a dictum. Here in mechanical ventilation, lungs are already damaged, so you don't want to cause additional lung injury. That is the prime goal. Maintain gas exchange, maintain the acid-base balance at a level that is appropriate for a specific patient. You will never try to bring the values to the normal range. Your only aim is to maintain gas exchange and acid-base balance levels at an appropriate level, individualized for a particular patient. Accepting hypercapnia and hypoxemia wherever indicated, they can be accepted. They are called the permissive hypercapnia and permissive hypoxemia, and ensure patient ventilator synchrony. This is a very important thing you need to do if you aim at reducing the work of breathing. Yes, you know, the workout breathing is a parameter that you want to take control over by intubating the patient and mechanically ventilating the patient. If the patient and ventilator are not in synchrony, the patient is giving his own breaths, ventilator machine is giving its own breaths, there can be you cannot achieve the goals. So selecting a mode and ventilator settings that best match the patient's respiratory drive while ensuring lung protection and obtaining the maximal patient ventilator synchrony are your goals in mechanical ventilation. Tidal volume and alveolar distending pressure. You target a tidal volume of 8 to 10 ml per kg ideal body weight. If the lungs have been already damaged, you use the lower tidal volumes. 4 to 6 ml per kg of tidal volumes are also enough. An acceptance of VT in a given patient must be judged relative to alveolar distending pressure. Then what is the alveolar distending pressure? Alveolar distending pressure is ascertained by measuring the end expiratory flat tube pressure. To measure flat tube pressure, usually a 0.5 to 2 second end expiratory breath hold is applied and the ventilator can calculate the flat tube pressure and it will show the flat tube pressure. Your target of flat tube pressure is 30 centimeters of water. You should not go to a flat tube pressure more than 30 centimeters of water. As there is something called as PEEP, positive pressure that will remain in the airways at the end of the expiration or end of exhalation. Extrinsic PEEP can be used to increase oxygenation. Henry's law states that S gas is equal to Kh into partial pressure of the gas. Increasing PEEP will increase the pressure in the system. So when you increase the PEEP, it can open or splint airways that may otherwise be collapsed at the end of expiration, and the decreased atelectasis improves the alveolar ventilation, and improved VQ matching can be achieved by increasing the PEEP. Extrinsic PEEP is also significantly decreases the workout breathing because the alveoli doesn't have to expand and collapse every time when a breath is taken. The alveoli are splinted into a position of open position. They don't have to do much work. So what are the clinical applications of PEEP? Usually you start at a low PEEP and increase as tolerated and dial to patient comfort and desired oxygenation levels. Keep a flat tube pressure below 30 centimeters of water. Follow the map as you are dialing up or down the PEEP. Removing the PEEP may precipitate a new pulmonary edema and patient might need a reintubation. So whenever you are going to wean off the patient, don't take up the ventilator suddenly when the patient is on an extrinsic PEEP. Keep reducing the PEEP, achieve a PEEP of less than 8, then you can try to wean the patient from the ventilator. So what is the recommended PEEP? PEEP is usually recommended for patients with ARDS. Mild ARDS patients will require a PEEP of 8 to 15 centimeters of water. Moderate to severe ARDS, you can go up to 20 centimeters of water. For most other patients, a PEEP of 5 centimeters of water is reasonable when there is no lung injury and it maintains the functional residual capacity and can prevent atelectasis. Hemodynamically unstable patients and patients with a large bronchopleural fistula, a PEEP as low as 0 can be kept, but most of the ventilators doesn't allow you to decrease the PEEP below 3 or 4 millimeters of mercury. So that is the lowest PEEP that you can use. There's something called as Auto-PEEP or intrinsic PEEP. Extrinsic PEEP is the positive end expiratory pressure that you apply through the ventilator. Intrinsic PEEP is the one which develops inside the lungs when there is patient, especially when there is patient mission in asynchrony, and this leads to your reduced dynamics. Usually patient exhalation will permit complete emptying of the air in the lungs. The positive pressure that develops in the alveoli when the lungs fail to completely deflate is called PEEP. So it happens usually because of breath stocking in patients, especially with COPD. The alveoli cannot collapse completely and expel the complete air, leaving the residual volume. So with each breath, the alveoli go on distending to reach its maximum level, and finally it completely fails to deflate. So when the alveoli go on distending with each breath, some volume of air is left over in the alveoli and they go on distending. It creates a pressure on the system, that is auto-PEEP. When it repeats with each cycle, the pressure increases pathologically. This can lead to compression of the right atrium, and when there is compression or pressure over the right atrium, venous return can be decreased, and this can lead to your accentuation of the shock in a patient. This can also lead to increased fatigue pressure and can lead to barotrauma. So when the alveoli are not collapsing, they are kept at high pressures. You need more and more work by the chest and the lungs, so that there is increase in work of breathing. It increases oxygen consumption and CO2 production, thereby increasing the need for ventilation, prolonging the duration of ventilation, increasing the respiratory rate, and worsening auto-PEEP, and it sets up a vicious cycle. Once auto-PEEP develops, it goes on increasing unless you detect it and try to correct the auto-PEEP. So what are the factors that usually lead to development of auto-PEEP? If there is an airway inflammation and there are mucus plugs which generate dynamic airflow obstruction, so when air is entering inside the lungs, it can go through around the mucus plugs, and when it is coming out, the mucus plugs are obstructing. So there is some air left out in the bronchioles. In case of high lung compliance, as in chronic obstructive pulmonary disease, as I already told, dynamic airway collapse and air trapping occur which each breath stalking happens, and the alveoli go on increasing until a pathological PEEP develops. High tidal volume ventilation, low time for exhalation, and slow inspiratory flow generating a higher inspiratory to expiratory time ratio, all these can lead to auto-PEEP. So how are we going to treat auto-PEEP? Basically, you can treat auto-PEEP by decreasing the respiratory rate, and will increase the time between breaths and decrease the inspiratory to expiratory ratio, YE ratio, to 1:1.5. So allowing more time for expiration will let out the let out more air during exhalation, so decreases the auto-PEEP. Increasing the respiratory rate to 60 to 100 liters per minute and assure fast delivery of air during inspiration, lending more time for exhalation allows auto-PEEP to be reduced. Utilize a square waveform for ventilation delivery, which we will know when we will talk about the waveforms for the mechanical ventilation. Reduce the tidal volume. Use 6 to 8 ml of tidal volume. Decrease the respiratory demand by decreasing CO2 and lactate production. Minimize the work of breathing. Control fever and pain. Ensure adequate sedation. Control anxiety and treat sepsis. These are the modalities you can use for treating auto-PEEP. So continuing with the physiological goals of mechanical ventilation, as we already discussed, you need to reduce the work of breathing. Your aim is to reduce the additional lung injury. And when you talk in terms of oxygenation and CO2 removal, we spoke about permissive hypoxemia and permissive hypercapnia in selected patients. So these are the target values for mechanical ventilation. When it comes to PaO2, the patient is having normal lungs, you can aim a PaO2 of more than 80 millimeters of mercury. The patient with ARDS, you give a permissive hypoxemia. In both ARDS and COPD, use somewhere around 55 to 80 millimeters of mercury. In COPD, 50 to 65 millimeters of mercury of partial pressure of O2 is enough. When it comes to carbon dioxide, if you're dealing with a normal lungs, try to achieve the normal CO2 levels, that is 35 to 45 millimeters of mercury. If you are dealing with a lung injury, allow a permissive hypercapnia up to 80 millimeters of mercury will not cause any physiological abnormalities. pH, the lungs are normal, you try to achieve the normal values for pH. The lungs are injured, any pH more than 7.2 with other parameters being normal, you can allow. The terms used for classification of mechanical ventilation. You might have heard so many modes of classification of mechanical ventilators. What are the terms used in classification systems? First and foremost is the control variable. The independent parameters which are targeted by the ventilator mechanism are called the control variable, and all other variables are dependent on this control variable. Usually control variable used is pressure, volume, and time. Breath sequence, a particular pattern of spontaneous under mandatory breaths is used. You can use a continuous mandatory ventilation or continuous spontaneous ventilation or intermittent mandatory ventilation. This is called the breath sequence. Targeting scheme is the method of feedback control used to deliver a particular pattern of ventilation. So control variable can be pressure or volume. Breath sequence, it can be a continuous mandatory ventilation. Actual rate may be greater than the set rate, which the patient triggered breaths. Backup rate is minimum value in case of apnea. Intermittent mandatory ventilation, which is most commonly used method of ventilation. Spontaneous breaths are allowed between mandatory breaths. Backup rate is the minimum value if apnea occurs. Continuous spontaneous ventilation, patient is completely conscious. All breaths are patient triggered breaths. Targeting schemes used are set point, dual, servo, adaptive, optimal, and intelligent modes. So what are the criteria that are used to determine the control variable during inspiration? By previous observation and knowledge, check whether the pressure waveform changes when the patient's resistance and compliance change. If it doesn't change, go for pressure control. If it changes, you can choose one of time control or volume control. Look whether the patient's waveform change when the patient's resistance and compliance change. Volume waveform, you can go for time control ventilation. With a pressure waveform changes, volume waveform doesn't change. Look at, is the volume measured and used for control of the volume waveform? Go for volume control ventilation. If not so, go for flow control variation. Criteria to determine the breath variable: observation and previous knowledge. Look whether the inspiration is initiated by the patient's ventilatory drive. The patient is not able to initiate a ventilation, you go for a mandatory breath. The patient is able to initiate a ventilation, is inspiration terminated by the patient's lung mechanics or the ventilatory drive? If it is not the case, you go for a mandatory ventilation. If the patient is able to initiate and terminate his own breath, you go for a spontaneous ventilation. There are some operational algorithms that you need to know. Phase variables are used to initiate a particular phase of the ventilatory cycle. The trigger variable initiates the inspiration. Patient triggering can be recognized by the ventilator as a pressure signal or as a flow signal. Pressure triggering occurs when the patient's effort causes a drop in the airway pressure. Flow triggering occurs when the patient's inspiratory flow reaches a clinician preset level. The limit variable is the pressure, volume, or flow that can be exceeded during the inspiratory phase. The cycle variable is the pressure, volume, flow, or time that terminates the inspiration. First generation ventilators were typically pressure cycle ventilators. With pressure support ventilation, the breath is usually flow cycle. With volume controlled ventilation, the breath is volume or time cycle. With pressure controlled ventilation, the breath is usually time cycle. Does the patient start Because a preset pressure is detected, inspiration is pressure triggered. No. Does the inspiration start because a preset flow is detected? Yes, the inspiration is flow triggered. No. Does the inspiration start because a preset volume is detected? The inspiration is volume triggered. No. Whether the inspiration starts because the preset time interval has elapsed, it is a time triggered ventilation. No. Inspiration starts when preset diaphragmatic activity is detected. It is a neurally adjusted ventilator assist, which is an advanced mode of ventilation. Does the peak pressure reach a preset value before inspiration ends? Inspiration is pressure limited ventilation. If that is not the case, does the peak volume reach preset value before inspiration ends? It becomes an inspiration volume limited inspiration. If that is not the case, does the peak flow reach preset value before inspiration? This is flow limited ventilation. None of these happens. No variables are limited during inspiration. And does the inspiratory flow ends because the preset pressure is attained? Yes, the inspiration is pressure cycle. Does the inspiratory flow end because the preset volume is attained? Inspiratory flow is volume cycle. Does the inspiratory flow end because the preset volume flow is attained? Inspiration is flow cycle. Inspiration ends because a preset time interval has elapsed. Inspiration is time cycle. Inspiration ends when a preset diaphragmatic activity is detected. Neurally adjusted ventilatory assist. So there are two waveforms, beginning with the patient effort. The first graph is showing flow pattern, second graph is showing the pressure pattern. A certain pressure is reached, a certain flow is reached, then the flow starts. When the pressure is lowered to a particular point, then the pressure starts. Beginning of patient effort here, and then pressure is lowered, then the flow starts. Pressure increases, reaches a maximal point, and then comes down. Conditional variables are used by the operational logic system of the ventilator to make decisions on how to manage, control the phase variables. Computational logic is the description of the relationship between ventilatory settings, feedback signals, and breathing pattern to add detail about how the mode operates. Targeting scheme is the one which determines the feedback control algorithm. Clinician adjusts specific static set points as pressure limit to tidal volume or inspiratory flow as the targeting schemes. Dual targeting occurs when breath starts out with volume control and switches to pressure control, ends in the pressure control. Ventilator modes. With continuous mandatory ventilation, all breaths are mandatory. All breaths are spontaneous with continuous positive airway pressure. Patient's inspiratory effort is assisted by a preset level of inspiratory pressure during pressure support ventilation. With synchronized intermittent mandatory ventilation, both spontaneous and mandatory breaths are delivered, and mandatory breaths are synchronized to the patient's efforts. With full ventilatory support, a ventilator does all the work of breathing for the patient. With partial ventilatory effort, some of the work is provided by the ventilator and the remainder is provided by the patient. There are mainly two important modalities of mechanical ventilation used. One is the volume controlled ventilation, the other is the pressure controlled ventilation. Volume controlled ventilation, tidal volume is the constant variable. Inspiratory pressure is usually variable. Clinician sets tidal volume, flow pattern, peak inspiratory flow, respiratory rate, and the trigger sensitivity. In some ventilators, inspiratory time, minute ventilation, and IE ratio are set instead of VT and flow. If the inspiratory time is longer, and the time required to deliver the VT and end inspiratory pause will result. Pressure control ventilation. A fixed pressure is applied during the inspiratory phase. Inspiratory time, IE ratio, and trigger sensitivity are set by the clinician. In newer generation ventilators, clinician may also set the raise time, which is the time required for the set pressure to be reached. In pressure support ventilation, pressure, pressure is the limiting variable. Only set variable with pressure support ventilation is the pressure support level. Respiratory rate, inspiratory flow, and tidal volume are all patient controlled. Pressure support ventilation is usually used for patients who are able to spontaneously breathe, or patients who are put on non-invasive ventilation. The ventilator cycles to exhalation when inspiratory flow decreases below a set level. So the main differences between pressure controlled ventilation and volume controlled ventilation. In pressure controlled ventilation, VT is variable. In volume controlled ventilation, it is constant. Peak inspiratory pressure is constant in pressure controlled ventilation, variable in volume controlled ventilation. Phi plateau is constant in PCV. It is variable in VCV. Flow pattern is variable in PCV. VCV, it's set. Peak flow is variable in PCV. It is set in VCV. Inspirated time and minimum rate are set both in PCV and VCV, depending whether you're using a continuous mandatory ventilation or a continuous spontaneous ventilation. Flow and flow pattern. Major difference between PCV and VCV is the flow pattern. With ECV, flow is set. With PCV or PSV, flow is determined by the set pressure, patient's demands, resistance compliance of the lungs, and the algorithm that is used by the ventilator to determine all the operational algorithm. A distinctive flow pattern occurs in pressure control ventilation. Flow pattern can be set in during VCV. Inspiratory force in PCV with no patient triggering, inspiratory time or IE ratio is set. For a specific pressure and lung mechanics, there is an inspiratory time beyond which there is zero flow. Decreasing the inspiratory time below point of zero flow eliminates the plateau and decreases the delivered tidal volume. The length of end expiratory plateau changes with changes in lung mechanics. As compliance decreases, the end expiratory plateau time increases. As resistance increases, the plateau time decreases. With volume controlled ventilation, the clinician must set an end inspiratory pause to achieve this effect. The plateau remains constant unless changed by the clinician. So until now, you know about the basics of ventilation, the lung mechanics, and the modes of ventilation. Now, what are the things that you need to monitor during ventilation? During volume control ventilation, during pressure control ventilation, they are different. During volume ventilation, you monitor the pressure, ventilator trigger breaths, peak inspiratory pressure alarm at 5 centimeters of water above average peak inspiratory pressure. Patient trigger breaths, you set a PIP alarm 10 centimeters above the average PIP during mechanical ventilation. In pressure ventilation, you are going to monitor the volume, ventilator triggered breaths, low VT or VE alarm below 50% of the average volume. In patient triggered breaths, a low VT alarm below 50% of average VT can be set. Advantages and disadvantages of PCV. Peak inspiratory pressure and peak alveolar pressure are kept at constant level, so the chances of lung damage are minimal. Flow also varies with patient's demand, potentially decreasing the likelihood of asynchrony. Increased patient demand increases the potential for delivery of injurious tidal volumes. Varying VT leads to abnormalities in blood gas balance. It's more difficult to rapidly identify major alterations in lung mechanics when you're using a PCV. Advantages and disadvantages of VCV. The major advantage of VCV is the delivery of a constant tidal volume. So volume trauma is minimized. It ensures a constant level of alveolar ventilation and results in easily identifiable changes in peak inspiratory pressure and plateau pressure as the respiratory mechanics change. Fixed potentially contributes to asynchrony. The volume is fixed, it can contribute to patient ventilator asynchrony. Thank you. For any doubts, you can inbox me. Please don't forget to subscribe and share the videos for getting these videos directly into your inbox whenever I upload. Thank you again.